We will discuss a very hot topic in TAVR about bicuspid aortic valve. Uh, as all you know, that the bicuspid aortic valve is a common congenital heart defect affecting up to 2% of the population. Bicuspid aortic valve accounts for up to 50% of patients requiring surgical aortic valve replacement, and this is more evident in younger population. As TAVR become a therapeutic option for younger and healthier patients, bicuspid aortic valve will be seen more often in the next future. So why the bicuspid aortic valve anatomy is always challenging? There is a lot of causes and a lot of factors make the bicuspid aortic valve is challenging when you deal it with TAVR. Why asymmetrical calcium, most commonly fused RAFI, is asymmetrically calcified, can cause valve to tilt or push lower during deployment. Of course, increase the risk of paravalvular leakage. High calcium burden. Calcium in bicuspid valve is a metablastic snarl calcification, and will increase the risk of stroke, pacemaker, and root rupture. Elliptical annulus, more in type 0 valves, and new studies have shown type 1 valves are less elliptical than we thought, and always we noted that in bicuspid aortic valve we have larger annulus than we expect, and about 30 to 40% of the bicuspid aortic valve has associated with aortic aneurysm and aortopathy. And I will show you two cases and why the bicuspid aortic valve is more challenging. As you can notice it here, this is female patient, 67 years old, and always we noted that bicuspid aortic valve in younger population. She is morbid obesity, had a paroxysmal AF, she had attacks of syncope, she had severe aortic stenosis with mean gradient 55 millimeter mercury. After hard discussion, she referred for TAVR for her morbid obesity. And this is her echocardiography, and you can appreciate here the mean gradient. And you can appreciate here, this is type 0 bicuspid aortic valve. As you can see, this is her CT. And you can appreciate we have three types of bicuspid aortic valve: tubular, flared, and tapered. And you can measure, as Dr. Muhammad mentioned, you can measure the annulus in different ways. So you can perform traditional measurements at the annular level or at the LVOT, and you can appreciate the intercommissural distance, which will measure it 4 millimeter above the annular plan. All these diameters is very crucial and very important in bicuspid aortic valve to avoid annular rupture. And you can appreciate here this angle showed that we have a transverse aorta. The angle is very acute. So after crossing the valve and after dilatation, we can't cross with the valve. This is evolute R, and we did a lot of maneuvers and to cross the valve, but we failed. And you can appreciate here, every time the ballooning do the same. And after proper dilatation with bigger balloon, we saw that we can cross with the valve. As you can appreciate here, this is another dilatation with bigger balloon. And every time the recoil is very high, as you can appreciate here, and we failed to cross the valve after all this pre-dilatation. So how to solve this? This is to change the wire, and we changed the wire for more stiffer wire, but we can't cross two. So we did like barrel wire, stiff wire in the LV, and after we did, as you can appreciate here, there is two stiff wire in the LV, and after that we succeeded to cross the valve, and uh, we deployed the valve, and you can appreciate here the valve is very constrained, and this is typical picture of the self-expandable valve or any platforms in the bicuspid aortic valve. Another case, as you can appreciate here, this is 60 years old only. He has shortness of breath, orthopnea, paroxysmal nocturnal dizziness. He diagnosed as complete heart block 3 years before his presentation with severe aortic stenosis. He admitted in cardiac unit many times with decompensated heart failure, and he was diagnosed as severe aortic stenosis 1 year before the admission for TAVI. He has type 2 respiratory failure due to severe form of lung fibrosis, and this is why after heart team with his age, they preferred to do for this patient TAVR, not surgical aortic replacement. And you can appreciate here, this is another type of aortic stenosis, and it's type 02, and it's not clear where is the leaflets, where is, and I expected that this patient I will have more challenging in the crossing, but uh, to uh, to cross this valve, it was a mess. As you can appreciate here, we tried AL1, AL2, right Jotkin, Bigtail, Lima Caster, Tromo wire, normal straight wire, BTC wire, with rapid basing, without rapid basing. I did everything to cross this valve, but all were failed. So we did injection to see where is the opening, and you can appreciate here it's not clear. And after this injection I tried, but we spent like 90 minutes to cross this valve. So how to solve this? I thought that I can cross this valve antegradely via transvenous septal puncture, and you can appreciate here this is interatrial septal puncture. And after I crossed from the left atrium to LV, the valve is crossed. You can appreciate here the wire was crossed very easily. And after my wire in the aorta, I snared the wire. You can appreciate here I snared the wire from the aorta to work again via transfemoral aortic valve. And you can appreciate here this is how I snare, and this is very crucial. You have to be very cautious not to cause any damage for the mitral valve apparatus. And now my big tail in the LV after snaring, and my wire in the LV, and it's normal TAVI. This is pre-dilatation. As you can appreciate how the valve is very tight, and here this is a typical form of the bicuspid aortic valve. This is another self-expandable valve, and post dilatation, as you can appreciate here, and this is the final result with excellent positioning of the valve, and his LB function is improved. So bicuspid aortic valve anatomy has tackled in many different registries and in many trials, and always we have a procedure under expansion in all types of bicuspid aortic valve, and this is more evident from a lot of registries. And bicuspid should not be considered taboo anymore for catheter-based replacement. I mean, we have to deal with the bicuspid aortic valve when we need TAVR with the proper platform and with the proper preparation for to tackle TAVR. And this is a lot of paper and a lot of publication discussing the difference between bicuspid and tricuspid aortic valve, and all favor to avoid TAVR in bicuspid aortic valve when it is combined with aortopathy or aortic aneurysm. And TAVR is a feasible option among a selected patient with bicuspid aortic valve anatomy, but the higher rates of moderate to severe paravalvular leak, annular rupture, and cerebral ischemic events observed in the bicuspid aortic valve. So some recommend to put a protection device, cerebral protection device, before tackling the bicuspid aortic valve, and this is according to the protocol in some centers. So my summary is bicuspid aortic stenosis represents a heterogeneous anatomical cohort. Close attention should be paid to the valve morphology, calcium burden, and pattern. Data shows similar device success, mortality, and paravalvular leak, perhaps higher rates of stroke, pacemaker, and root rupture. So we have to deal cautiously with the bicuspid aortic valve. The current data suggests bicuspid anatomy is amenable to TAVR with current generation TAVR technology with acceptable clinical outcomes. Thank you.